the disease, I think it's better to put them on treatment. You don't wait, oh no, this is mild, you come after 2 years. They come, they have lost vision. Grade 2, moderate damage. They still have these field defects, aqueous scotomas, and the thinning of the neuroretinal rim. Neuroretinal rim, that's the space between where there is the cap and the edge of the optic disc. It means the bigger the cap gets, the smaller the rim gets between the edge of the cap and the actual disc. So where someone has got extensive capping, they will have very thin neuroretinal rim. Where the capping is just beginning, there will be at least a bit of neuroretinal rim. Then we have grade 3, severe damage, extensive visual field loss, and marked capping. An end stage where you have just a small residual neuroretinal rim. All this grading is all nice, but I think what matters to the patient is the vision. It's the vision. If you catch up with a patient in grade 4, you know, they should know where they stand. You know, you catch up the patient in grade 1 or grade 2. If you explain to the patient nicely, they will know that if they don't come regularly for their checkup, they may end up blind. And once you mention that, look, if you don't come routine checkup so that we keep a hold of what is happening here, you'll be blind. A lot of people will double. They will come to you. They don't. No one wants to be blind. It's not a pleasant thing, you know. What is this? Oh, it's not even there. See, this is the disc. There's no capping here. Yes, no capping. But you can see in this picture here, all this is a cap at the center of the disc. And this is the neuroretinal rim. The edge of the disc is there. Here too, the capping is this is smaller capping. This is increasing capping. And this space between the edge of the cap and the edge of the disc is the neuroretinal rim we're talking about. So as the cap enlarges, that rim gets smaller. All these. So when you are examining for glaucoma, these are you have to look at the disc. You have to look at the disc. If the disc looks reasonable, small cap, amount small in the center cap is, I think, within normal. But once it starts enlarging, then you know there is damage occurring there. Mind you, there is no pain in glaucoma. No patient will come and know I've got pain, you know, unless they've got glaucoma, which is which one? Yes, unless they've got angle closure glaucoma. That's when they may come with pain. But even without pain, they can come with severe glaucoma, primary open angle glaucoma. So pain is not really, you know, it only helps you to differentiate the angle closure and the other types. But the severity, you have to look at the eye, look at the pressures you are getting, look at the visual field, the sight being lost when you do the visual fields. So when you do glaucoma, Please, let's take the intraocular pressure. Let's do the visual fields to see how much vision is remaining there. Let's do all those things. There's also a thing called normal tension glaucoma with clinical features similar to primary open angle glaucoma. Sorry? What's the difference between the normal tension glaucoma and open angle? I'm coming to it. The intraocular pressure is within the normal. You've taken the pressures within the normal, but when you do a fundoscopy, you find the evidence of cupping. Yeah? Normal tension glaucoma. Although the pressure is normal, they are showing signs of glaucoma damage. That's the one we are referring to as normal tension glaucoma. Okay. The pathogenesis, how it occurs, is not fully understood, but the sudden or gradual decrease in the vascular perfusion to the optic nerve head may occur, resulting in glaucomatous optic atrophy. Okay. Despite the normal intraocular pressure. That's what might happen. Visual field defects are deeper and closer to fixation. Deeper, not like you're jumping into, it means severe, they are severe, and closer to the point of fixation. Differential diagnosis of this normal tension glaucoma. One is primary open angle glaucoma, presenting initially with a normal intraocular pressure because of wide daily swing of intraocular pressure. But when you do the phasing, you can differentiate. Congenital optic disc anomalies, you may think it's glaucoma. E.g. coloboma may be mistaken for cupping. Neurological lesions may present with field defects. But when you are looking there, everything is looking normal, but someone has a field defect. But if you follow the field defects, you find that it's not coming from the eye. It's not coming from the eye. Any questions, ladies and gentlemen?
Good morning, doctor.
Good morning.
I wanted to ask, what would happen if someone has a pressure too low, much lower than 21?
31. A pressure too low. There's no evidence of injury or no history of injury. Hello?
No.
Retinal detachment. Prof. Why you for your course? Retinal detachment.
You know that
I'm
also in my own work.
Okay, sir.
What is it?
She's asking, what if the pressure is very low?
How low? I think maybe less than 11 or below 11.
I think
who is asking, so we need to get it from her.
Hello, mommy. When you say low, how low is the pressure you're talking about? Hello? Who was asking? Banda. Eh? Tasila. What do we do?
Well, she needs to clarify what she
Exactly, yes.
you can't
But a low pressure normally, maybe injury.
But what one you do,
Mm.
and by the point to go can't function.
Mm.
And it may lead to allergy, like you say.
And most of the people, they will come even when the RD is there. Retinal detachment. Hello, questions. Yashua is Tasila. Madam Tasila. Why is she not on?
Hello, doctor.
Yes.
I think what she meant is, what if a patient was to present, they don't have any other signs of glaucoma, but their intraocular pressure is well lower than normal. I understand the normal is somewhere 21 millimeters of mercury, but they present with an IOP reading lower than that, but they don't have any other signs of glaucoma.
Okay. This is what I was saying, that when you say no any other signs of glaucoma, it means the disc looks normal. Are you with me? It's the pressure which is low, but the disc is looking normal. This is what we're saying. Possibilities would be a retinal detachment, or I think some injury of some sort. That's there's a perforation of the globe leading to hypotony. Otherwise, with everything normal, it's very unlikely that you can have a pressure so low that it becomes a worry for the patient. Are you with me? Sorry, sir.
If the pressure went low, too low, the eye will undergo automatic shutdown.
Yes, exactly.
And it becomes the physical eye.
Hello.
Oh, yes, doctor. I'm clear now. Thank you.
Oh, yeah, clear. Okay, thank you. Any other question, please? If everyone is happy.
Doctor, I had another question, please.
Yes, please, yes.
I wanted to ask, assuming you receive a patient, they don't have any signs of glaucoma apart from cup disc ratio, which is quite big, but the readings are uniform in both eyes. Yes. I wanted to ask what investigation you mentioned to say you put the patient on you just monitor the patient, but I wanted to ask if there are any investigations that you would advise calling on such a patient.
Let me first be clear what you are talking about. You're saying the patient has signs suggestive of glaucoma?
They don't have any signs apart from
no signs of glaucoma. Okay.
Apart from an abnormal, the pressure is fine as well, but the only thing that's there is
pressure is okay. You're saying
the pressure
fine.
is okay as well.
Okay.
Yes.
So what's next?
There's only damage. I wouldn't say damage, but the reading on the cup disc ratio is the only thing which is slightly abnormal. It's
cup disc ratio slightly abnormal.
Yes, it's above normal, but uniform in both eyes.
It's a normal patient. It's a normal patient. There are no signs of glaucoma. The pressure is normal, apart from what appeared to be a big physiological big cup.
So that shouldn't raise any eyebrows.
When you check the visual fields, they are normal.
Yes.
There is no glaucoma. despite the cup appearing big, if there is no field defect, it's not glaucoma. It's not glaucoma, but yes. What I would, if I'm not sure about what is there, give the patient 2 reviews in a year and see if there's any changes. But definitely that's not glaucoma. But you don't also throw them away. Tell them, look, we want to just follow a bit to see if something else will come up. Because despite having what appears to be a big cup, there's no evidence of damage. The fields there are normal. So I think the way to go is give them a good review date. Because they will not come every week. They can come after 2-3 months. You check again and compare with the previous results you got. Again, give them 2-3 months and you compare. You see if the readings after 2, 3, 4 checkups are still the same. It's physiological. No need for treatment. Okay, my dear.
Yes, doctor, thank you.
Any other question, please? Okay, this one we're done. We'll look at another topic. Now we do close down. Angle closure. Jimmy is in the meeting. Okay. Lectures.